And I have a few of my colleagues here that are all going to kind of help facilitate and take notes today. So I have Bill Osborne, our intensive services unit manager, Kalina. How do you pronounce your last name, Kalina? I've never said it before.
It's Bathkey, just a bath and a key put together.
Got it. Our rules coordinator for OHA, Zach Thornhill, our civil commitment policy program lead for intensive services. Ben Teeth, I'm not sure if he's here, but he's also on the intensive services team. He's helping us keep track of the feedback and make sure we don't miss anything. And then Rachel Ellis, who's our intern, is going to be helping try to share screen and write down your feedback as you're saying it so you can see it reflected back. And then there's a few other folks from our intensive services team just listening in. Kendall Batiste Ball and Blanca Fernandez. And then I think Ben is floating around in here somewhere too. So that's the OHA team. There's a lot of us here, but we all just want to make sure to help facilitate and keep things on track and make sure we're not missing any of the really important feedback that you're all providing. So this is the continuation, part 2, a little bit of a do-over, a little bit of a follow-up from our January 5th Civil Rule Advisory Committee. Sorry, I'm getting over a really bad flu and I might be coughing a little bit. And just as a reminder, this RAC is just focused on the proposed rule changes alone, not affecting the entire rule set, including the ones that OHA has not proposed rules on. Kalina will be reading the rules, the proposed rule changes as we go. And then, like I said, Rachel will be writing in your feedback as we go. There will be future opportunities after today as the ongoing rules process to give input and provide insights and feedback, including written feedback to our group. And then just a reminder, we do understand session has started and that everyone is really kind of frenzied and trying to track along with all the new stuff that's happening, but we are on that 180-day tight time cycle for rule changes. And so that's why we decided to go ahead and have today's session, and we didn't want to get too far away from January 5th. So that's just the kind of opening frame. We're gonna, as Kalina reads, Bill and I will try to help facilitate your questions and your comments. Bill's gonna provide a little bit more, where have we been, what are we doing today, and where are we going next? Because I know these civil rules are pretty complicated and they touch lots of different pieces of the overall rules. So I'm going to hand it off to Bill to kind of give a little bit more context for today, and then we will kick it off from there.
Great. Thanks, Jesse. So hi, everybody. So I wanted to give just some context about kind of where these rules came from and what we're planning, what we're trying to do here. So back in the early fall, the intensive services team was approached and was asked to draft some rule changes to help OHA and CMHPs better communicate essentially about where people under civil commitment are physically located and accessing treatment. And in the course of some legal affairs, we received some feedback that individuals under civil commitment were being lost in our system. And so in an acknowledgement that we can do better at standardizing how this information is tracked and shared, we submitted 4 temporary rule changes that were essentially effective on October 14th of 2022. And I'm going to go through those rule changes really quickly and then can answer questions if folks have them. But essentially, in Rule 309-033-0210, we made an initial attempt at reworking definition sections for clarity and ease in reading. Was that a question? Nope. Okay. In 309-033-0270, we made it more clear that the superintendent of Oregon State Hospital, who oversees admissions to Oregon State Hospital, is the one who oversees admissions to Oregon State Hospital and not the director of OHA. In 309-033-0290, we established what we're calling the placement order form and the submittal process for that form as a way to standardize communication between CMHPs and OHA. And that really is around where those folks under civil commitment are located and how they're accessing treatment. And then the final one was 309-033-0291, 0330, where we removed a section of the rule that allowed a CMHP to discharge a civil commitment due to lack of placement, because we were told that that was actually not legally sound. A civil commitment can only be discharged if it expires at 180 days, or if the person no longer meets criteria as a person with mental illness. And so that rule was changed to bring our rules within the line of the law. So we submitted those temporary rule changes. We have essentially set in motion that we have to complete these rule changes within 180 days in order for them to convert from temporary to permanent. And our 180 day is April 11th. So that's why we're doing this particular RAC right now. This is by no means tackling the entire rule. So we understand that those rules, that the OARs need a revision from top to bottom, because essentially it's been decades since we've done that. And so the only two questions I'm going to pose to this group, and I don't need an answer today, but I think as we start to move forward, is how we want to do that. Do we want to do rule changes essentially in sections and then have a RAC for each section? Or would it make more sense for us to essentially have multiple, listening sessions and work groups, go through the entire rule set, and then have one large RAC at the end of that once we've all kind of fully reviewed the rule and fixed what we think needs fixing. So if folks have an opinion on that, I would love to hear it. Please email me or Jesse or Zach, and then we can continue to have that conversation. So unless there's any questions, Jesse, I'll turn it back over to you.
We're just hoping that context and where we've been and what we're going to try to do today was helpful to you all. Before I turn it over to Kalina to start the rules, I just want to see, did we miss anything, Zach, or is there anything you want to make sure the group hears before we get started?
Yeah, I'll just, so just to let you all know, tentatively right now, the plan had been to do the rules in chunks. And so every 4 months we would do, so this year at 4-month increments, we would have essentially 3 racks for 3 chunks of rule changes. So the next rule changes would be tentatively up at the end of May, and then the other ones would be started at the end of August, early September. So that would be the schedule if we did go throughout this year in the chunk. So I wanted to make sure you had that context, you had an idea of what it is you're kind of weighing, either essentially doing what we're doing now, which is a bunch of community engagement and then a 140-page document, and then we do a RAC for that, or we can do it in chunks. And it's just what's going to meet your all's needs the best.
Yeah,
and the input, Rochelle, would be by email. So if you want to email me, Jesse, Bill, all of us, one of us, but let us know by email, that would be great, because right now we don't necessarily have time for conversation and dialogue about that, unfortunately.
Thanks, Rochelle. Deborah, I see your hand. Go ahead.
Thanks. I just wanted to ask if you're considering, you had mentioned that these rules haven't been updated in quite a long time. And it just so happens that right now we're having this comprehensive work group through OJD. And so I'm just wondering about how you're thinking about the timing of that. Why, after all this time, do it now and not wait for that group to finish?
Well, in initial conversations we had around that, the legislative work group is going for the 2025 session, which means whatever happens at that time, nothing would be enacted until 1/1 of 26. And so through OAR, we actually have the ability to make some changes on a quicker time frame and meet the needs of what's in those rules and what the community is presenting with. So it's just the faster timeline and the expediency in that.
And we can do some follow-up, Deborah. I don't know if there's others on that work group besides you, and I think Bill attends for us, just to understand alignment better. And then in addition to the OJD-led civil-related work group, here at OHA, we've tried to stand up a monthly drop-in meeting for all the CMHPs to come to. And if it makes sense to include the hospitals in that, we're happy to do that, just to try to really improve conversation and dialogue around challenges with civil commitment, make sure we're hearing you, responding, and have a place to come together. So I'm going to pivot us then to dive into the work. We really tried hard to get out what folks asked for, a redlined or track changes version, really reflecting all the changes that have been made. So we've sent that out a few times. We hope that we hit the mark with that document and that was helpful to you. And with that, please just raise your hand. We'll also monitor the chat. Bill and I will try to help facilitate questions as they come up. And with that, I'm going to hand it to Kalina to go ahead and get us started.
All right, let's get started. Let me just share my screen. So give me 2 seconds. All right, so as previously mentioned, we did get started on most of the rule set. So we're going to jump right into chapter 309, division 33 for rule 0625. A second. Sorry, just trying to bring over everyone onto another screen.
Hey, Kalina,
all right.
you might want to enlarge it if you can kind of zoom in a bit, make it yeah.
So sorry about that.
Yeah, that's a lot better. Can folks see everything okay? Does that work for all of you? I guess raise your hand if it doesn't, if you can't see it or if it's not big enough. Okay. I think we're ready.
Thank you. Sorry, my nerves took the best of me there. All right, so for this rule set, the summary is to update provider language to LIP and updated person first language. So as you'll see through most of the text, it's again, primarily changing that position to LIP and a couple grammatical things here and there. I know we've had a lengthy conversation about this and some person first language from the previous RAC. I just want to give time for folks now to pose more questions on that. Otherwise, I'll make sure Rachel continues to copy and paste those comments from the previous RAC onto here. But I wanted to give folks an opportunity to comment. All right, hearing none.
Hold on just a moment, if I could.
Sam.
So this is Sam Dixon from the Licensing Certification Unit. One of the pieces of this rule is outdated because this rule was actually written prior to a statutory change that came later. If you scroll up to this top, thank you. We no longer require a 2-physician hold. The language around this part of the rule is something that used to be referenced when we did require a 2-physician hold, but they changed the statute removing that language.
Sam, really quick, I'm not sure if you could identify which part of the rule you're referencing, that would be great. And I do just want to remind folks that in a RAC, it's the official RAC members that are given the space to provide the verbal and oral feedback. So if you do have additional comments and you aren't part of the official RAC, if you could just submit them in writing so we can make sure we get through the rest of the rules in a timely manner, that would be fantastic.
Okay. I'm referring to paragraph 2, where you talk about the physician and either a consulting physician or qualified mental health professional.
Correct. Yeah, thank you for that. We did take that out in one of the other sections, so that's a good catch. Appreciate it.
I see Danielle's hand up.
Hi, yes, thank you. My name's Danielle Meyer, Director of Public Policy for the Hospital Association. And thank you for the comments this morning. I think what I heard Bill and others say was that we were going to go through the sections of rule that were changed in the temporary rule and not the other sections, but by my read, 0625 is a part of the larger proposed draft changes. So I wanted to re-ask that question.
Sure.
Thank you.
So this RAC is to review any of the changes, the proposed rule changes at this time, which are inclusive of the temporary rule changes that were effective on October 14th, but do include some additional changes to bring us in line with statute, which is where the modification of physician to LIP and things like that fall in, because our statute references LIPs, not just physicians.
Thank you.
It's just a little bit, a few other things are included beyond just the temp rules, Danielle. Kind of a cleanup. And can you just remind the group what LIP stands for, Zach?
So it's a
That acronym.
licensed independent practitioner, and it includes a physician, a nurse practitioner, or a naturopathic physician. It's defined in our civil commitment statute, so 426.005.
Great. Go ahead, Danielle.
Follow up for you. So we are covering the 124 pages that were sent out on January 3rd that were then revised on January 5th, that entire package, or?
So the RAC membership received the proposed rule changes actually at the second week of December. And since the RAC membership is the body that gets to comment during the RAC, that is a decent amount of time to review. But yes, it would be the full document with multiple of the same changes throughout, with substantive changes in about 5 of the rules.
And there'll be plenty of time for written comment and other follow-up. Danielle, this is just to get the RAC input today. Does that make sense? Or do you still, it looks like your hand is still up.
My apologies, I didn't mean to keep my hand up. I'll think about that for a second. Thank you.
Okay. All right, let's keep going then. I don't see any other hands.
All right. Yeah, for most of this section, it's just changing physician to LIP and a couple grammatical things. You'll see in paragraph 4, subsection C, just adding clinical record a couple of times in that paragraph, just for clarity. But again, physician to LIP a couple of times, that person first language, in that subsection G, custody is under civil, the person who was in custody is under civil commitment, and the
Are
physician
you a member of this RAC? Question mark. I am not. Period.
Go ahead, Kalina.
Thank you. Does anyone have any more comments about this rule?
Now, it looks like Jack might have. Jack, did you have a question for us? You might have just not had your mic muted.
I didn't have my mic muted. Forgive me.
Okay, no worries. We just didn't want to skip over you if you had a question. Okay, keep going, Kalina.
All right, thank you. All right, we're moving to Rule 630, the administration of significant procedures in emergencies without the informed consent of a person under civil commitment. For this rule, the changes were just to update person first language. As we've already discussed, that first paragraph changing to person first, and then for subparagraph A and B, taking out the names of those rule sets, and then again throughout the rest of the text, changing to person first language and taking out those titles of those rule numbers. And I believe that's it for that one rule. Any comments? Matthew.
I'm just wondering here if it would be helpful to remove the sort of like redefinition of emergency again. It seems like this is, I'm not sure if it's helpful or not, but we have what constitutes an emergency in every one of these sections when the term emergency is actually defined. So we could just leave this at if an emergency exists in the opinion of the responsible physician or nurse.
Sounds good. I saw a lot of head
Did you
nodding.
capture that, Rachel?
Yes, sorry. Yes, it just takes a minute for the comments to
Okay.
upload. Sorry.
Got it. Technology. Any other comments or questions before we move on? And just noting what Zach put into the chat that there's a general public comment period open from February 1st through the 15th, and we can receive comments, more written comments, anything you don't share today, or if you're not a RAC member, please get that to us, and we'll definitely take that under consideration.
Correction to
I have
that.
a quick
Public comment
question.
is open through the 21st of February. Sorry about that.
Oh, great.
You're good.
So almost
And
the
then
whole
I heard
month.
someone try chatting.
Yeah,
give you
I
the
just
floor.
have a quick question. Where the first person language where it says person under civil commitment, I thought that we had additional or a different oh my gosh.
Yes.
A different phrase for that because it was a differentiating between a person who was already adjudicated and then a person who was not yet adjudicated, because what this would mean is that they're adjudicated before they even went through the process already.
Yes, so we haven't updated the text yet since the last RAC, just to make sure we're all still on the same page in what we currently had. So as you'll see right now, Rachel is adding that additional comment, and she'll be doing that throughout the rest of the text, especially on those bigger comments that we had at the last RAC. So don't worry, you're still being very well heard, and your comments are definitely being recorded. But thank you for bringing that up again. I really appreciate it.
Okay. Yeah, I just wanted to make sure because I thought my understanding was that we were going to look over the comments that are the additional changes that were going to be made based on the comments that we had during the last session.
No, so that will be during the public comment period, which we can talk about a little bit more towards the end of this RAC. But right now we're just focusing on the rest of the rule changes that we had not yet discussed at the previous RAC.
Okay.
But yeah, we can talk more about the public hearing or the public comment period towards the end of this, but thank you.
Okay.
Matthew.
Looks like Matthew has his hand up too.
Yeah, thanks. Sorry, I just had one other change under 630. Under 3B, it says if the person is legally incapacitated. I think that is a little bit confusing when we have a decision around capacity from a physician and from someone who's going to be determining capacity in a clinical sense versus the legal sense. And so it may be easier to have this say if the person has an appointed legal guardian rather than saying if they're legally incapacitated.
Great, thank you. Great. Any more comments or questions, suggestions on this rule? Hearing none, keep it moving. All right, so Rule 640, involuntary administration of significant procedures to a person under civil commitment with good cause. Here we clarified acronyms, updated to person first language, removed assistant administrator, and updated to the authority. So similar as before, updating to person first language, we took out a rule title here for subsection A and B. Clearly define this acronym APD as aging and people with disabilities. For subsection C, updating those acronyms appropriately in subsection D. Person first language in paragraph 2. Taking out that title of the rule number in paragraph 2, subsection C. Changing from physician to LIP in subsection D, and then person under civil commitment. And I'll be sure that Rachel continues to copy and paste those comments, especially from the for that person first language comment. Thanks, Rachel. Matthew.
Matthew's got it. Oh, great.
Thanks. Yeah. So the requirements for the independent review under this section are extremely onerous and make it almost impossible to actually provide a significant procedure for good cause, because the requirements that someone be a psychiatrist, but also not be an employee of this facility or in a position to provide primary on-call treatment, and have received training from the medical staff regarding the meaning and application of these rules, means that it has to be someone who's outside of the organization, who can't be an employee and can't be in a position to actually provide any type of treatment or care for this patient, but also who has to have somehow received training from the hospital itself. And with the requirement that they personally examine the person, means that there's almost this sort of impossible confluence of factors that have to come into play for someone independently to actually provide care or provide a significant procedure for good cause. And so I would recommend striking the not be an employee of the facility language. And I think there are other, I'd be curious to hear other people's thoughts on this, but it's a very, very sort of overly complex, and actually I think causes more harm than good in terms of being able to provide these significant procedures.
Thanks, Matthew. Alicia, then Robin.
No, I just want to echo what Matthew's saying. We were reviewing these again and felt the same way from a hospital perspective. So, thank you.
So, and under the suggested language, being an employee of the facility, is there any other suggested language there?
My question is on this, and I don't know which Alicia you were trying to call out here, but so I agree with Matthew on this. I think this would make it especially onerous on rural areas or rural hospitals that are already struggling with capacity issues. The issue, do we have, I guess my other question was, do we have, or is there a definition of good cause? I don't remember that at all. And I'm sorry.
We have that defined somewhere, Zach.
There's not a definition of good cause in civil commitment statute or OAR.
Okay.
Are you suggesting maybe that we need one?
Well, maybe, perhaps, but I don't know, because I don't know if that would make it even more of a pain, because I think the overall concern is that maybe one practitioner's idea of good cause is not necessarily the same as another practitioner's of good cause. Mm-hmm. And that can include or, be led by or informed by personal bias, lived experience, and so on and so forth. So I think it's really important that if the two-step process is being removed or was removed statutorily, where two physicians have to agree to it. So that's being removed. And then now understanding that like this process itself is very onerous, and it makes it very difficult. And this, places a lot of hardship on rural areas to actually do this or go through this process, and can be harmful. Where is kind of the accountability to the people who are having to go through this process?
Yeah,
that's going to be my question. And I think the good cause piece is what's my concern, which it may not be anything.
Yeah, thanks for flagging that, Alicia. Robin, I saw your hand, and then Matthew.
I was going to say, actually, one second. So I just want to keep note for everyone. These are really great comments, which you're going to parking lot until the next RAC, when we're going to go in a further in-depth review of these rules. For this RAC, we're just going to pertain to the changes of the rules that we have now and some of these bigger ideas. While we love to hear them, these will be incorporated and worked through the next set of RACs while we do that thorough review and in-depth look through, if you will. I just wanted to add that there. Robin.
Yeah, just a point of clarification. I've noticed this red line that we're using is different than the one that was sent out. So as I'm trying to follow along, it's a little confusing. Is there a reason we're using a different, and it's not a red line, it's a Word document, let's be clear, because there's still not been an actual red line that tracks back to the language you've removed. So is there a reason we're not using the same document that was sent out?
I thought this was the same one sent out, Robin. Sorry about that.
To my knowledge, this should be. Oh, actually, Helena, it should be the document at the beginning that says "Do not edit."
Oops.
1 second, everyone.
Thanks for raising that up, Robin.
You're welcome.
We did all this prep too. Darn it. Trying to get our ducks in a row. All right, let's just give Kalina a minute. Matthew, I saw your hand up. So while Kalina's getting their doc up, did you want to make your comment, Matthew?
Yeah, thanks. So the section I was talking about, the question was asked about what other changes we should have around who the independent examining LIP is. I think the requirement to be a psychiatrist and to be in a position, not be in a position to provide on-call or primary care treatment is fine. I think that still follows the spirit of this and having it be an independent physician. But I think the requirement about not being an employee of the facility is by far the biggest issue that we see here, because it doesn't even allow another psychiatrist to do it who's maybe in a different department. But at the same time, the primary or on-call care piece, I think it also creates a lot of problems, because sometimes these patients really do need to receive medication, and good cause does exist. And like I mentioned earlier in the comments too, good cause is also defined under section 2 above. It's where a person is deemed unable to consent, refuse, or withhold or withdraw consent to the significant procedure, and the proposed significant procedure will likely restore or prevent deterioration of the person's mental or physical health, alleviate extreme suffering, or save or extend the person's life. And so with that piece of it, one thing that I actually think is potentially problematic with this is that the significant procedure doesn't necessarily have to be psychiatric medication. It could be a medical procedure that's a significant procedure. And so in that situation, having the independent examining LIP be a psychiatrist doesn't necessarily make sense for all significant procedures.
Good points. We will incorporate those in. And then it sounds like the definition for good cause is in there, Alicia. So maybe take a look, and then maybe you can provide written comment if the current definition isn't meeting the mark. Robin, I don't know if your hand was up again or if that was from earlier, but I just wanted to give you a chance before we dive back in. Okay, maybe not. Looks like you took your hand down. All right, Kalina, now that we're in the right document, and Robin, if you wouldn't mind just kind of double, triple checking with us to make sure this lines up with what you're seeing, just raise your hand if something looks off. I'll hand it back to Kalina.
All right, thank you. Sorry about that, everyone. All right, again, going back into it. So we're just changing physician to LIPs, and then changing to that person first language. And I'm sure Rachel's right behind me, trying to get into this document too, and adding those comments in those areas, especially around that person first language. And again, throughout most of the rest of the text, it's just changing from physician to LIP, and that person first language. And that's what I'm seeing so far throughout the rest of this text. And it's a little bit of a longer one. But again, just changing from person first language, physician to LIP. Took out in a couple of places, especially in paragraph 7, subsection B and C, taking out the titles of those rule numbers. And then again, physician to LIP. And then taking out assistant administrator and changing that to authority. All right. Went through that last bit a little quickly, so please let me know if you have any comments or suggestions on those edits that we just went through. Otherwise, we can keep going. All right, hearing none, please speak up if you do still have comments, though. I'm happy to go back. So the next rule, we are planning to repeal Rule 650, which was the variance section. As we talked in the previous RAC, we're moving all the variances up into a different rule that was at the beginning of all this, these rule changes, excuse me. And so this is just the text being crossed out. All right, moving into Rule 700, which is the purpose and scope. And here we just updated to person first language. And I'm sure Rachel's right behind me here to make sure that the comment on person first language is being incorporated here. Now the lag here is a little slow, so just give us a second. Does anyone have any additional questions for purpose and scope here? Otherwise, we can keep going. Please let me know if I need to slow down for anyone. All right. So similar to before, for 710, which is the definitions, we combined all the definitions into one section, which is at the top of the rule sets. And so here we're just showing the repealed text being stricken out. Just keep scrolling. Sorry for the whiplash here. All right. Zach, I see a note here says that the rule was not touched and removed for final review. Are we still good here? Are there any?
Nope,
Do we need to
you can
review this?
remove. You can. Oh, hold on. Scroll through it.
I guess there's one.
Yep, there it is.
Okay, sorry about that. So for 720, the application, training, and minimum staffing requirements. Here we're just updating that provider language to LIP. So as we just saw for paragraph 3, subsection A, from physician nurse practitioners to LIPs. I believe that's it for this text. Any questions for 720? That was 720. Yes. Sorry, brain slowly slipping. All right, 725, medical services. Here we're just updating language to LIP. So as same as before, physician to LIP in multiple instances here. For paragraph 4, it was physician, a psychiatric nurse practitioner to LIP. And this is consistent throughout the rest of this text. Any questions on 725? Or comments? All right. Again, feel free to stop me at any point. 727, structural and physical requirements. Here we fix some spelling and grammatical errors. And it looks like some person first language too. Especially in that first paragraph, we took out who are considered dangerous to themselves or others shall, instead with mental illness or with alleged to live with mental illness. And I know we've talked about this during the last RAC. So I'll be sure that Rachel ends up adding those comments here that we had in the previous RAC. But I want to give people the time and space if they have any additional comments on that, or if they would like to reiterate what was stated before. All right, we're going to keep moving on. All right, so that was it for that rule text or rule number. Does anyone have any comments on that overall rule in general? Hearing none, keep going. All right, 730, seclusion and restraint procedures. So here we updated the provider to LIP and changed computerized to electronic. So similar to before, physician to LIP, taking out nurse practitioner, then adding here registered nurse. For subsection B of paragraph 2, LIP to physician, or physician to LIP, and then registered nurse. And then as you'll see, again, physician to LIP for this section here for B, change computerized to electronic. And then similar as before, LIP or from physician to LIP. And that's that for that rule text. Any comments, questions, suggestions? All right. 732, time limits. Here we updated provider types to LIP and fix some spelling errors. Excuse me. So for paragraph 2, we changed it to or in writing. Some grammatical fixes here from physician to LIP, similar through paragraph 3, physician to LIP. Same with section 4, and going through, looks like that is it. And then some LIP or from physician to LIP at the end. Matthew.
Thanks. So I just noticed that under paragraph 2, it still says computerized medical record when I think we were above, we were changing it to electronic. I think electronic medical record is the terms generally used. And then under 6, medication not being used as a restraint. That's one that I know issues have been run into with that because chemical restraint is a viable medical practice and is generally authorized by federal laws. And obviously needs to be medically indicated. And but I would recommend either removing or amending that to allow medication to be used as a restraint in certain circumstances.
Great, thank you. I see another person. Amanda, I think, is the next person on my list.
Thanks. Yeah, I was just piggybacking off of Matthew. For diversions, for 14-day diversions, it actually says in the paperwork that you agree to the use of chemical restraint if necessary. So.
Thank you. Gordon?
Yeah, like my experience with even the term chemical restraint is that it's like largely being used less and less and sort of out of favor. And even the way that we're thinking about medications being used in these circumstances is more for treatment of symptoms than it is for restraint, even if the symptom that we're treating is extreme agitation. So I'm actually in favor of having language that moves us towards using medications for treating symptoms and not for restraint means.
Thank you. All right.
Before we move on, I'm just wondering, trying to reconcile these for like a good suggestion, and maybe we can think about this and send more suggestions in writing, but is it more about compelling meds and removing the word restraint altogether? And I don't mean to ask more questions than I know we need to move on, but just curious if there's other thoughts on how that can be worded. Go ahead, Matt, and then we can move on. Maybe so as folks think about it, you can send us some written feedback.
Yeah, and I'll just say I agree with Robin's comment that, you know, chemical restraint is dated language, not trauma informed. And I'm not, I guess what I'm trying to say is I'm not arguing for the term chemical restraint itself. I just think that saying medication cannot be used as a restraint is sort of, I think that there's a way that this can be worded to make it clear that medication is appropriate to be used for treating conditions such as agitation, extreme agitation, where the primary reason the medication is being used is to get the patient to relax and calm down so that they don't injure themselves or others.
Okay. We'll incorporate that in. We can work on this, and if anyone else has further suggestions, please just follow up in writing with us, and we can move on.
Sure.
Okay, I see Alicia still has her hand.
Oh, sorry about that.
You're good.
I was just gonna say that maybe it's something as simple as just making the statement that medications are not going to be used solely, you know, as a form of restraint or to restrain a person. And then couple that with some of the other information that Robin and Matthew just gave about that actually like using medication, or the use of medication being based on medical necessity or need. You know, so maybe that could be a good bridge there, to just state that it's not there just to restrain somebody because you're having a hard time with him, or or with him or her or they.
Yeah, that's helpful.
So I don't know.
Thank you, Alicia. Yeah, I think we have some good stuff to work with here. We can move on unless there's no more hands.
Yeah. Thank you, everyone. All right, let's keep going. All right, Rule 733, documentation. So here we've updated the provider to LIP and replaced AMH with the division for relevancy. So in paragraph 2, physician to LIP, for 4, AMH to the division. And those were the only changes to this rule. Any questions, comments? All right, let's keep going. All right, 820. The denial of payment. Oh, sorry, Matthew.
No, sorry, I was a little late on that.
You're good.
Is the healthcare supervisor defined in 733? Each use of restraint must be reported daily to the healthcare supervisor. Is that I don't remember seeing that as a defined term.
I don't recall that it is, and I would actually turn to some internal folks to figure out exactly who they mean by that, whether that means the director of the behavioral health unit, the chief medical officer, chief psychiatrist, what have you. So we can definitely take note. Thanks,
Great,
Matt.
thank you. Yep.
Thank you. All right.
Rachel, it's up above too in number 3.
Thank you.
Yeah.
All right, back to 820. So the denial of payment for services to persons in custody or on diversion. So here we removed assistant administrator and updated to the authority, updated provider to LIP, and simplified language and removed rule titles related to the denial of payment. Similar to what I just said, assistant administrator to the authority, that was done a couple of times. Clearer language determines that there is insufficient evidence. Taking out that rule language, rule title language, excuse me. Then again, in paragraph 2, the authority, LIP, the authority again. And that seems like the remainder of the changes is just changing from assistant administrator to the authority or division to authority. And then in paragraph 4, subsection A, taking out that rule title, subsection B, physician to LIP. And that looks like it is it for that rule. Any questions or comments here? Matthew.
I just keep speaking on these, sorry.
You're good.
So my thought around this is we're sort of shifting around definitions again. What must be demonstrated under 1 is mental illness, dangerous to self or others, and that's it. And we're sort of leaving out the inability to provide for own basic needs. And so I'm not sure what direction everyone's trying to go with this, because there are certain holds and other situations where an entity that's placing a hold or putting a person into custody because they are suffering from a mental illness and they are unable to provide for their own basic needs would theoretically be able to be put on that hold, but then the custody would not be paid for because it doesn't meet criteria here. That's my thought.
I think one of the things we had mentioned at the last track, Matt, was because you identified for us that the oversight in adding basic needs into the custody is that our statute for custody is actually only about the dangerousness. And so the commitment to change group, the legislative work group, that's something that we can bring to them about a legislative change to redefine how it is we allow people to come into custody, because it's not, basic needs is not included in there. And this part of the rule is about the one that you just mentioned is about custody.
Yeah, and I was thinking though, and I may be wrong on this. I was thinking that there are situations where someone can be put into custody when they are unable to provide for their own basic needs. But I may be wrong on that. I was thinking I was referring previously in our last RAC to the hold under 231 and 232, which are specific to danger to self or others and in need of emergency care or treatment for mental illness. But I don't remember if there's another way that would apply here, and I need to look into that. So just wanted to raise it for posterity.
Yeah, no, thanks for that. And yeah, we can definitely review and bring it to the legislative group as well.
Alicia.
Yes, so two things. I guess going back to the whole idea about, oh my goodness, where it's 1A, when it says mental illness. Is that the definition we're using? Are we in this context, are we using a definition, the legal definition, right? When you're going through the whole adjudication process or whatever? Or is this like the clinical definition of a mental illness?
It's a good question. And I'm wondering if, yeah, we can, yeah.
This term should not be mental illness. The term should be mental disorder.
So, yeah, demonstrated, yeah.
Okay, good. So now that's, okay, so we're good on that. Now, on B, where we talk about dangerousness to self or others as evidenced by thoughts, plans, means, actions, history of dangerousness, or other indicators of imminent dangerousness, which division believes are within accepted community standards of professional knowledge. Okay, that right there is like a load. I'm just gonna, like, I understand dangerousness of self or others as evidenced by thoughts, plans, means, actions. Stop. I understand that. I do not understand what the history of dangerousness has to do with a current civil commitment.
Throughout the investigation process, history of behaviors and actions can be included in your report.
So
Okay,
Alicia,
so
is your suggestion that we?
Well,
Sorry.
no. So my question is because of the way that it is written is that it doesn't necessarily have to be an imminent danger to themselves or others, but someone who doesn't show and doesn't have any indicator of imminent dangerousness, but has a history of dangerousness. By this, it looks like someone could, with a lot of wordsmithing, actually do or have someone go through this process, even if they're not showing imminent danger to self or others. And my question is that in statute? Does it have to be imminent?
Yeah, the fourth prong allows for if you've been committed twice in the last 3 years and you're decompensating in similar ways to the previous commitments, you can be committed under that prong, which would be about alone the history and not necessarily the eminence.
Okay, so then maybe that's something that needs to be said here, though. Is that
okay? Yeah, we can make note of that and consider putting that in.
Yeah, the history of dangerousness as described in whatever section you're referring to. Because I think this is good. This is just like the other one or during the last RAC. This is it provides a lot of ability for subjectivity to, and a lot of bias to show up here.
We'll make note of that too, Alicia. Thank you. Amanda, I see your hand up.
Thanks. I have a few responses about statutes. So the fourth prong, we call that expanded criteria, even though those words never appear anywhere in the statute. But that's what we call that. It is in 426005 FC4. Who, unless treated, will continue to a reasonable medical probability to physically or mentally deteriorate so that the person will become a person described under either subparagraph A or B, which is the definition we've already been talking about, danger to self, danger to others, basic needs of this paragraph, or both. I will say I don't know how folks want to do it here, but I will say most of the other places in the civil commitment statutes, it's kind of a silent fourth. Like everybody kind of knows it's there, but it doesn't get listed. I don't really know why that is.
Do you have a recommendation, or maybe think about it? Follow up in writing is better. Amanda,
again, any of these written comments that are related to legislation, we can make sure we pass on to the legislative work group as well. And Deborah is here, who's on that work group as well. So she's, I'm sure, taking note somehow.
Matthew.
Matthew.
Thanks. Just real quick, wanted to call out my comment, which does have the statutory citation for the director's hold or director's custody, which deals with the dangerous to self or others, or also unable to provide for basic personal needs and not receiving that care. Which is different from what applies at a hospital, but still can apply in the community.
Thank you. All right. Oh, Brian.
Yeah, I just wanted to say, related to what Matthew was just saying, a director designee can place a person in custody for inability to care, but only if they are on trial visit. So once the person has to have already been committed and released on trial visit, and then they can use inability to care as a criteria for having the person placed in custody in the community and taken to the hospital for a evaluation. But it still doesn't mean that they're going to have an NMI written.
Thank you. All right, Alicia.
Just a clarifying question, is this particular section, this is for hospital and non-hospital facilities, correct? So that would include law enforcement, sheriffs, departments and stuff?
No, those aren't considered non-hospital facilities.
Okay, so it wouldn't be part of this. And so law enforcement would not be part of this section then?
No, this section is about the denial of payment for two hospitals or non-hospital facilities for the treatment, care, custody of folks on diversion.
Okay, yeah, I just didn't know if there was overlap there between the two. Thank you.
Thank you. Brian, you still have your hand up. Are you good, or do you still have another question?
I'm good.
Okay, no worries. Thank you. All right, we're going to move on to the next rule. All right, which was 830, which was the variance section. So similar to before, we're moving that up to a combined section of all the variances, and this is just the repeal text. All right, on to 900, which is the statement of purpose and statutory authority. We just updated to person first language, and I'm sure Rachel's right behind me. Gonna update that comment similar to what we've already talked about between this RAC and the previous RAC. But does anyone have any questions or comments here? Brian, I still see your hand up. Do you have another question? Otherwise, I can help you lower your hand. Oh, never mind. All right, keep this train moving. All right, 9:10 was the definition section, similar to the other rules. We are combining all the definitions into one section, which is at the front of this rule set. So here's just that repealed language. Sorry for the whiplash there. All right, 9:20, the certification of mental health investigators. Here we've updated to person first language, removed assistant administrator, and updated to the authority. So again, you'll see that person first language. Rachel's already on it to add those comments from before. So we're on top of that for paragraph 2, subsection CB. Again, that person first language, which again, Rachel's on top of it. Other than that, I'm not seeing any additional edits here. Oh, another person first language, which again, I'm sure Rachel's on it. And then assistant administrator to the authority. And that is it. Sorry, Matthew, I just wanted to get through that last little bit. Floor is yours.
Oh, no, you're fine. Sorry. I'm actually one section ahead, so I'll wait.
Oh, good. No worries. Anyone else have any comments or questions for this? Oh, Matthew? Still holding
Sorry,
on?
accidentally clicked the button. Yep, I'll wait.
Okay, no worries. All right. Good on this section. Keep it moving. All right, 9:30. I know we've already kind of went over this last time. We were planning to skip it. But Matthew, it sounds like you still have a question or comment for this section. So I want to give you that time.
Guess I don't even my hand up again. Yeah, thank you. So in this one, I know we did talk about it last time. I just wanted to bring up one other thing. So we work with the Confederated Tribes of Warm Springs pretty frequently, who they do have a licensed behavioral health program that is a CMHP. And so this section it's helpful to say we want to receive information from tribal nations. However, I mean, this is something that I think could use a rework when determining the jurisdiction for investigations by a CMHP, because there are lots of issues with county court jurisdiction versus the investigation that's required under the statute and under the other regulations here, which in many cases require the CMHP in the county court to actually conduct the investigation. And so, for example, if a person arrives in Madras, which is in Jefferson County, depending on the origin of how they got there may be a statute in play that requires the Jefferson County Circuit Court and Jefferson County CMHP to be conducting the investigation when the person is actually a domicile on the reservation and a member of the Warm Springs tribes. So
I just wanted to clarify for you, Matt, and for the RAC, that this was developed. This actually is from the Tribal Affairs Department within OHA, and directly from them. So I'm definitely happy to take that feedback back to them and see if there are some additional legal pieces that they want to revisit. But this isn't necessarily about the jurisdiction of the investigation, that this is really about just background information and history on a person. Mandating that CMHP investigators, or the civil commitment investigator, obtain information from the tribe as appropriate and understanding who the person is, not necessarily for that tribe to conduct an investigation. Because sure. I mean, the only tribal org that could is Warm Springs at this point.
Got it. Okay. Yeah, I wasn't sure if that was an issue that applied to any other CMHPs or tribal behavioral health groups or not. So thank you.
Thanks, Matthew. All right, we're going to keep moving on to the next rule, which is, drum roll, 940, the investigation report. And so here we just updated to person first language. And given the comments that we've already received, we'll make sure to take note of those here where that update exists. Which pause, is paragraph 6 toward the end of that rule, where we change from person is committed to person is under civil commitment. And I already see Rachel there, ready to write down that comment. All right, does anyone have any other comments about this rule in particular? This is 940. All right. All right, we have 950, which is the certification of mental health examiners. So here we updated to person first language and replaced assistant administrator with the authority. So that person first language, I already see Rachel there who will incorporate those comments from which we previously talked about today and the previous RAC for all of those instances of person first language. See that a couple of times in this text. And then in paragraph 5, we just changed it from assistant administrator to the authority. Does anyone have any comments for 950 here?
I have a question, actually, Kalina. If you could scroll up to, I believe it's paragraph 1. Paragraph 2A. So it's currently changed from severely mentally ill to adults with severe and persistent mental illness. And I'm just curious, for folks, is serious mental illness or is SPMI still a standard that is used? We see both, and I just want to make sure that this reflects what is most commonly used currently, folks in the community. Or if SPMI is perfectly fine, then that's okay too.
It looks like Gordon left a comment saying they feel pretty interchangeable in their experience. Same with Sarah.
Okay.
Thanks, folks. Melissa.
I would just mention, since we're doing some wordsmithing with this to be more person-centric, that saying who suffer primarily from a psychotic disorder is not necessarily person-centric. So maybe that could be revisited throughout. There's a couple places in the document that I saw that.
Thank you for that. Yeah, that's a good catch.
Thank you.
Maybe something more like live with. Yeah, okay.
All right, any additional questions or comments for 950? I believe we only have a couple more rules to go through. All right, keep going. All right, 960, the mental health examiner's report to the court. And here we just updated to person first language, which will make sure to include those comments that we've already discussed so far. But paragraph 2 has that person first language. And I believe that might be it. Yeah, that looks like that's the only edit to this rule. Does anyone have any comments on 960, excuse me? I'm pretty sure this was actually the last rule. Oh, I apologize. 970, our last rule for variances. Another one of the variance sections that we are repealing and just combining into a one rule set, which is at the top of this document. All right. All that being said, we have officially gone through all of the rule text. We're going to bounce back to those notice statements that we talked about last time, including the fiscal impact, cost of compliance, and racial equity statements. So we'll jump back over there. I just want to pause for a quick second and see if anyone has any comments or questions about the rule text, just as the rule text. I see Alicia, you have your hand up.
Yeah, hi, and I apologize. I got cut off in the last meeting when I was on PTO, but the placement order, I know I didn't get a chance to talk about that, but I do think there's an opportunity to enhance that process. And because what's currently happening is if you have a CMHP issue, either whether it's a placement order or the other type of order to the patient, then the rules require that the patient respond in writing if they want to appeal it, and that doesn't seem very person-centered to expect a patient to do that, and who are they going to write, and who's going to help advocate and support the patient through that process. It doesn't seem that that would be the CMHP who's issued the order, or the hospital if they're here. It seems like the patient really does need somebody to advocate on their own behalf. And I'm just wondering if we can consider writing that into the OARs and looking at how that would happen so that the patient really does have good advocacy throughout that process. Thank you.
Thank you. Zach, did you want to add anything there?
About the placement order? Yeah, I mean, we can. So are you, I'm sorry, are you suggesting, Alicia, that in the placement in 0290 that we add in a space that allows for like a representative or a healthcare representative to be able to appeal on behalf of the person, or?
Right.
Yeah.
I mean, I think independent, whether it's an ombudsman or somebody, to go in and with the patient and say, you've received this order. Is this confirm that this is where they would like to be? And if they say they would not, help them write the letter and appeal, and then submit it and help arrange for the appeal process. I know, because what it happens is it falls on the hospital to do that. And, that I think really that patient would be best served if they had a ombudsman or somebody who's really just working on their independent behalf.
For sure. I'm not so, okay, so if I'm hearing that, you're suggesting we write in a piece of the rule that that says an ombuds will go in and do this with the person, or that they are allowed to?
I would suggest that they will go in upon like 72 hours of being issued the notice, meet with the patient, confirm that's where they want to be. If they don't want to be, then work through the appeal process with the patient and support them through that process.
Yeah, and that's a fantastic suggestion, and something I think we can take to the ombuds office. I do know that they are incredibly taxed, so I don't know how they'll receive it, but I think it's something we can definitely bring to them and see if they want to be written into that.
And then I guess
that group just grew. I think this is a really good suggestion to make.
For
Alicia,
sure.
do you, if it's not ombuds, do you have other suggestions on?
I mean, that's the challenge if the county is issuing. I would have thought it would be the county. So, or
the county level ombuds.
Somebody that's independent that can act solely on the patient's behalf through that process and advocate for them.
And I wonder if it's
maybe
something
like
too
ombuds or other advocate.
Yeah,
like
that. NAMI. I don't know. I'm not. I just really want to make sure that that patient has a good representative and they feel that they're supported.
Would it be? It's come up before where somebody had asked that we allow the public defender to do it on behalf of the person. Would that be sufficient as an addition
and
for
again,
you?
That's a resource issue, and I would leave that to them. I mean, that seems like that's who we have used, or we've recommended that happen. But again, that's the hospital calling for the patient or helping set up. Or is it the county that needs to give the patient the phone number for somebody to help them fill out the form and go through the process?
Okay.
But who helps the patient through that? Because the rule requires them to submit in writing that they don't want to.
Yeah.
Amanda and then Alicia. I don't know if you have something to add to this topic or a new one.
So it's kind of to add to this topic, and I know we can't solve this today, but this is the same issue I have with recommitment, where the patient has to affirmatively ask for a hearing and ask for an attorney, and I hate that, but I know we can't solve that today, so I'm just commenting.
No, I'm with you right there with you on that one too. So.
I think the recertification legislation is something our commitment to change group could definitely take up.
So I love the fact that Alicia brought this up, because I think in a lot of spaces I've brought this a very similar issue up, where especially when we're talking about people who are going to be considered as essentially not being able to care for themselves, right? They should have the ability to have someone who is independent and and has the understanding of how this process works to advocate on their behalf. And it should be an automatic process. It shouldn't be requested by the person who's navigating this process. This should be as soon as one of the in one of the multiple stops this goes through, as soon as it hits that particular stop, a advocate should be I guess dispatched to or somebody should navigate that, make a contact or have like a warm handoff to an advocate. And then at that point, if the client doesn't want to continue with it, then that's their decision. However, I would really not put this on the public defender. They're already overtaxed, and as we've seen in particular in Multnomah County, there are not enough public defenders to even represent individuals with quote unquote just criminal charges, let alone having public defenders who are also able to navigate this process and then advocate right on behalf. That's way too much to ask. So it could be peer specialists, people who have gone through this process before. It could be that there in every county, or at least in every region, there is a peer support or a peer specialist who has either gone through this process themselves before, or even know somebody who went through this process, or just simply are advocates or whatever. And I think that would alleviate some of this back and forth that we're having. And it would also add an additional measure of accountability and transparency, and autonomy for individuals walking through this process.
Thank you for that suggestion. I think exploring how peer supports can be better integrated into our civil commitment program across the state is something that we are interested in exploring. So do appreciate you bringing that forward as a suggestion.
Thank you for the opportunity to talk about it.
Great, thank you, everyone. All right, we're going to jump back into those statements really quick that we discussed at the end of the last RAC, to give us all enough time to go over the text and talk about it. All right. Hopefully everyone can see my screen again. Oops. Sorry, clicked on the wrong page. All right, so for our racial equity impact, we've written the proposed rule changes throughout the division that constitute in this rule change notice speak to the person first language and changes references of physician to licensed independent practitioner and LIP. This change ensures that the providers noted in OAR to provide pre-commitment and post-commitment treatment services captures a greater racial diversity of providers, which is in support of more racially just health outcomes. One aim in creating increased standardization statewide is to support baseline quality of care regardless of location in the state, with particular attention to regional and local cultural needs related to the population. A substantial change was added to 309-033-0930, Section 2, Part C, directs that civil commitment investigators must consult with an enrolled member's tribal supports as part of the pre-commitment process in seeking the least restrictive treatment options and settings available. Does anyone have any additional comments to this section? I know last time Rachel added this comment, but just wanted to go back to this if there's any more conversation we wanted to have.
Is there space available to maybe add a tidbit regarding goodness, I don't know how to say, I don't know, I'm not sure how to say it. I might just write it and send it in.
Yeah, thank you. Anyone else? Otherwise, we can jump straight into that fiscal impact. All right, hearing none, but we can always come back.
Kalina, I just want to give a time check for folks as well that there's just about 35-ish minutes left. So that's the time we have to chat about the fiscal piece at this point.
All right, so I'm going to read through both the fiscal impact statement and then the cost of compliance. And then after done reading both of those, we can go into a discussion. So for the fiscal impact statement, we wrote, the authority does anticipate that there will be minimal fiscal impact from these rule changes. In completing the placement orders, there will be an additional minimal time constraints placed on those designated to complete these forms and submit online. Additionally, the rule change in 309-033-0330 will lend to CMHPs investigating in more oversight of community-based civil commitment options, as it is likely that more people under civil commitment will be discharged from hospitals and other more restrictive settings to restabilize and reintegrate into their communities. For the statement of cost compliance, we wrote for section 1, identify any state agencies, units, or local government, and members of the public likely to be economically affected by the rules. We identified CMHPs, OHA, HSD, behavioral health, local hospital partners, community-based mental health providers, mobile crisis, social service agencies, and licensing and certification unit at OHA, and jail systems. For section 2, the effect on small businesses, we estimated none. For subsection A, estimate the number and type of small businesses subject to the rules, we said none there. For section B, describe the expected reporting, record keeping, and administrative activities and costs required to comply with the rules. We stated completion of the placement order on initial and transfer placements, increase reporting and tracking of the community-based commitments following discharge from hospital without discharge of commitment per change to 309-033-0330. And then subsection 3, the estimate the cost of professional services, equipment, supplies, labor, and increased administration required to comply with the rules, and we stated none. All right, that was a lot of reading. I saw the chat kind of go, or no, someone, it looks like they just left, but open to conversation. Ron.
Oops, sorry, I had to find the unmute. So in this section 1, you've listed a lot of organizations that you think are going to be financially impacted or economically impacted. And then in the section just above this, you had said that there's minimal impact. But this really seems like there's potentially a lot of impact. So how do you define minimal, and how did you do your evaluation to determine who would be impacted and what that would look like?
So I'll just, for context, I did check in with our fiscal analysts here internally, and this is not something that they actually do. They don't take a look at these proposed rule changes and then run fiscal analysis. And by minimal, I guess it was more of a minimal cost associated with the impact rather than minimal, stating that there was little impact, more of the cost associated with that. But of course, we can definitely have comment, and we'll make note in here to adjust accordingly.
So I would advocate that more work be done on this, because you know, it sounds like it's more of a guess that there's going to be minimal financial impact, but I think there needs to be a deeper dive to really see what that is, because that can add significant burden on a lot of those organizations that you have identified there, and they would be absorbing the cost unless OHA is going to cover the cost of any financial impact.
Yeah, thank you for that. And I think that's something we can clarify too, maybe Kalina, through y'all's team with the Secretary of State, like what the intention behind this section is like how much analysis is intended. Just because internally our fiscal analysts don't operate, it's not a part of their operations.
Yeah, and that's a great question. Something that I would have to come back to everyone with a more thorough answer. I am just under the impression these are under statutory requirement to go over and have written for each rule set. But I will definitely come back to the group, or at least to Zach and their team, with a more thorough answer there. But thank you for proposing that. Melissa.
I just want to back up what Ron is saying, and that this may be a statutorial requirement, but I definitely think that when we all read policy revisions and when the public reads policy and our elected officials, that this is not something that's just words on a piece of paper. And I think that when we're all adjusting to what we need to be doing differently to meet our community's needs, the fiscal impact and the sustainability of us being able to deliver services in the way that we should be is impactful. I think especially when we're talking about the civil committed population, which there's a huge shift that's undergoing with that. And so I think there does need to be careful consideration around what are the changes that are being proposed and how will those impact all of the delivers and the providers in the community around providing these specific services. Thanks.
Thank you. Does anyone have any more or additional comments for the fiscal and economic impact or the cost of statement of cost of compliance? Robin.
Yeah, I want to also echo what Ron and Melissa are talking about, because I think there's unintended and not necessarily well thought out costs of compliance with this, especially to the counties. And I haven't seen what the counties' impact statements are. I do know there's a lot of new work with some of the new processes that's not necessarily productive work, a lot of busy work, a lot of shuffling of papers. And there's not a lot of backup for any of that. So I just don't know that it's fair to say that this cost of compliance is minimal, that the fiscal impact is minimal. It just doesn't feel really great.
Thank you, Robin. Kathy?
Yeah, thanks. And just to piggyback on what Robin said, in terms of impacts to the county, I think one thing that needs to be considered in terms of the cost of compliance and financial impact, so we're in a situation where you kind of have a compounded cost. The monies that come to the CMHPs through the CFAs are generally less than what the cost of providing the services actually is. And there's at least in some counties, many counties, there's supplementation of services by county general funds because there's not enough money there to do the work to begin with. And when even a small task, which seems pretty insignificant because you're already at diminished capacity and workforce shortage and all of that, every addition on there, it actually hits harder because the capacity, you're working with less and less capacity. So it's kind of a compounded impact.
Thanks, Kathy. Alicia?
So I want to echo what the last few people just said. Now, my question is actually more in terms of if the team that came up or comes up with the fiscal and economic impact statement for this piece right here, if they are not, or if it's not their job to actually do any, I guess, in-depth financial analysis, how or where or when and who whose job is it to actually do that? If it's not the team that comes up with the financial or with the fiscal and economic impact statement, it's like saying the people who are coming up with the racial impact statement or racial and ethnic impact statement really don't have to do any research on the any disproportionality that may happen or may occur to BIPOC individuals who are going or have to navigate this process, right? Or even a disability impact statement, which we don't have. It could be individuals, which from my understanding, that is actually it is covered in a different section for individuals with intellectual and developmental disabilities. The civil commitment process, there's additional stuff that happens, but I'm having a really hard time with just getting an answer of, well, our team just doesn't do it. So at what point or who does this? And if it's nobody's job to really do it, then is this something that needs to be brought up to the legislature or legislators to make changes to the statute so that the people who are actually writing these fiscal and economic impact statements and racial and ethnic impact statements are actually doing their homework and utilizing data to make it? Because as we hear, and I'm trying to cut it short, but as we keep hearing about all the community partners here within this meeting, or a lot of community partners within this meeting are saying that, okay, well, this is the term minimal impact is really, it's not necessarily representative of what we as community partners see, with boots on the ground. So, who is, or at one point, will there be a fiscal or like an actual analysis be done? Two, or is there going to be an analysis be done? Two, if it's not this team that wrote the statement, who does it? And if not, or if there's none done, how do we fix this? How do we go moving forward to make it more representative of what the actual impact would be, rather than this higher, this kind of overarching perceived impact by someone or a group of folks who seem to not have the full picture, if that makes any sense.
Yeah, that makes a lot of sense, Alicia. We can take this back and I'll find out just from a leadership perspective if there's other resources that we have that can help with this from our rules work here at OHA, but I appreciate what you lifted up. I think we've captured it, and you're also welcome, if you want to put that in writing and send us a follow-up email. I'll definitely, you have my commitment that I'll follow up on that. I see a couple other hands up, and I think we're getting to a point of wrapping up. Go ahead, Ben.
Yeah, just related to the racial impact statement, we did meet with what is the name of the office? Office of Behavioral Health Equity. Is that the
Behavioral
name of
Health
the office,
Equity
Jesse?
and community engagement.
Yeah, so we did meet with them regarding these rule changes to get their advice on that statement. But as to the fiscal impact, I mean, I'll hand that one to Zach.
Right, but did anyone in that office have any actual understanding of the civil commitment process, or anybody who is really understanding? Yeah, I guess my question is, just bringing it to, the Office of Equity and Inclusion or the behavioral sector there really doesn't do much if you have a whole bunch of people looking at it and saying, oh yeah, this looks good, but they don't have an idea of what the impact of civil commitment actually does, or what the impact of civil commitment
I agree with you.
is.
In our Office of Recovery and Resilience, we have folks with lived experience in civil, but part of the next few months and getting feedback and engagement around these rule changes will include folks from our Office of Recovery and Resilience, and engaging with folks with lived experience, and not just lived experience in general, lived experience of the civil process. So that's work we've been engaging in and will continue to engage in. And I just really appreciate you bringing it up here too.
And
just a final hand, but it looks like it might have gone down. Excuse me, sorry folks. Kalina, back to you.
That's about it for this. I just want to keep the floor open in case anyone has any additional comments that they still want to air. We still have 20 minutes. Happy to close this early if we deem so. But again, I'm just trying to give people as much opportunity to comment either on these statements or on the rule text themselves. And I see Robin's hand up again.
Yeah, I just wanted to clarify. I know this is kind of, and maybe you said it at the top and I missed it. But I understand and appreciate the 180 days and the need to do that to revise the rule. What I don't fully understand is in that need to revise the rule, why can't we just go back to the beginning? Because many of these rules have had unintended impacts that have had concerns. There's not been sufficient time to take a look at what some of the new language is. I mean, what we saw today, we gave a lot of feedback a couple of weeks ago, especially around some very significant language proposals that created concerns. I still have questions of whether or not LIP can just be substituted in there wholesale, and does that match up with statutory language? Lots and lots and lots of questions in there. And so this feels like a very rushed, half-baked cake that's going to cause harm. So rather than push forward on this, nope, we got to do this, we're on a 180-day clock, help me understand why we're not going back to where we were before these temporary rules came in and saying, let's take a break, reset, and start this process after session. Yeah. And maybe I missed that part of the setup of this. And if I did, my apologies.
That's okay. Yeah, happy to kind of reframe or rephrase. Some of the rule changes, well, the temporary rule changes were essentially a directive in many ways, but we needed to adjust them for to address some of the legal concerns that were in them, in their content and the substance of them. So that's where 0330 comes in. That rule was not in line with legal standards for civil commitment as far as how somebody can how their civil commitment can be discharged. And then for the placement order process, that the process had always been in rule, but there was not a standardized process for communicating it between CMHP and OHA. And so the rule rewrite created that communication line and a way to communicate between CMHPs and OHA. In that process, we did find out from CMHPs like what was actually happening on the ground. How were they actually doing this placement, previously known as assignment process? And so with that feedback, we went back to 0290 and took out a lot of the defunct, sort of outdated processes that were from the 90s when we used facsimiles. But we don't do that anymore, really, at least not to the same degree. So we were able to modify, be responsive to that feedback and modify the rule even further to bring it more in line with what CMHPs are doing. And so 0290, I do believe, is a direct response to what CMHP said they do on the ground. And I feel really confident about that one being that responsive. And as far as the 180-day timeline, if we don't meet that timeline, it would revert back to previous rule language before the temporary change. And if we did that, that means the placement order would just go away. It would disappear. The 0330 change would disappear. It would be again allowed for CMHPs to discharge a civil commitment due to lack of placement, which would bring our rule back into non-compliance with legal standards around civil commitment. And so we need to avoid that.
And we still have time. I mean, like we said, this is I think, Robin, what you might have been referencing was the overall process, and that is going to be, most of this next year, we're going to be taking that on. The placement order is something that we were out of compliance with statute and are required to do it. And so we're being directed by our Department of Justice and by the courts around that one. So I still think there's time to do some of the more deeper reflection and review that you're talking about, unless I'm missing something. But I see that your hand is still up, so let me pass the mic back to you.
Yeah, no, I appreciate that. I appreciate the clarification around it's the US DOJ that's giving you the directive in that one very slim piece with the placement order. That one very slim piece in the placement order is probably maybe 1 or 2 pages of what are 124 pages of changes. And I also appreciate that you had conversations, as I understand. I haven't heard from AOCMHP that they've had these conversations, but you're saying you've had conversations with the CMHPs. Given that these have significant impact in processes that occur with Oregon's hospitals, I'm wondering where that engagement was, because that's a lot of what we're reacting to. Is a very sudden approach on some pretty, stunning changes to a lot of different things that impact our world that up until a few weeks ago was not something on our radar screen. So I guess it's kind of hard to hear that this is related to a change that you have to make in one very specific place, but it's 124 pages of change.
So I do, I want to address the
Zach,
LIP.
I got this. So Robin, before you got here, I just wanted to reference back to something I said in the beginning. We started a couple work groups in collaboration with AOCMHP, and it's been most exclusively a focus on working with the CMHPs around civil. And what I said in the beginning is I think we need to think about including the hospitals in those work groups. And being intentional about that, not just like a come one, come all, but actually be intentional about how we're all going to work together. And so I wanted to take that back I know Cheryl's not here today in the RAC, but I wanted to take that back with her and think through what that could look like so that we're talking with everybody together. So the word intentional that you raised, I want to say that too. It did, and I'll just own, we did start with that engagement with the CMHPs that are doing the civil commitment work. So apologies that hospitals weren't involved in that right away. We've only met one time. We just got these work groups going. So I think the time is good to get all the heads together. So that's what that engagement will look like. In terms of the placement order, I guess I would push back a little bit that that's the only kind of major significant thing. I think some of this language and some of these updates have been really good. The conversations have just been amazing just in this RAC and the last one. And I think the stuff that you guys are bringing forward will make better civil rules overall. We just, as a behavioral health community, need to do that together. And we're trying to figure out the best way to be responsive to you all, run the rules process that we have to run on the timelines, and be inclusive of the information, the reflection, the impacts that you guys are bringing up, and also acknowledge that we're dealing with almost 30-year-old rules that I think everybody, I've heard a lot of frustration. I'll just say I heard a lot of frustration about these outdated rules. So I think the intent is for this to improve and get current. But if there's ways we go about doing that aren't completely in alignment with what we're proposing today, we're happy to take that feedback and incorporate it. But we hope you'll join us on this ride, this year to improve these rules and get them in a place where everybody is happier with them. They're probably not going to be everything to everyone. Maybe the compromise is somewhere in the middle where hospitals, CMHPs, OHA, we can all try to strike a balance that we can all live with, but that's the intent and the hope. So I don't know if that answers everything you raised, Robin, but we'll keep at it. And Zach, I see your hand up. Go ahead.
Yeah, I just wanted to add to it, Robin. I know that you weren't included in the Providence meetings before, and frankly, I didn't know about you, and now I do. I know who you are, and I think that's part of the process too in community engagement is learning and meeting the people, right? But I do want to assure you that we did start actually with hospitals, and the first community engagement sessions we did start with were back in June, and so myself and my teammate Lisa Peets, and then Ben Tees, and Rachel Ellis, we all met with hospitals, if not twice, definitely once. All the hospitals that have behavioral health units and serve folks on an inpatient basis to understand their perspective around rules and how the rules were impacting the work that they do. And I think a big piece that came from that and the placement order process in general was an oversight. Like we didn't, in the rule language itself, from our perspective at OHA, we really read it impacting CMHPs, and it's clear that hospitals do feel that it impacts them, and that's something that we can definitely take feedback on and understand better, because we didn't necessarily include that in an assessment of how that's going to impact community. So, yeah, I just want to assure you that we did start with hospitals, and it's been happening since June, and now that as we're meeting more people and understanding who the players are a bit more, we can definitely reach out.
Well, let's be super clear. I was aware that you talked with some of my staff, and the way that was presented to us was not in the context of anything having to do with rule changes. This was in the context of more of a customer service survey to learn about how we were feeling about the process. So the disconnect really came at your intent. If you're going to come into my hospital and ask us what it is that we're thinking about, how, from a customer service and learning perspective, we're going to send you to a different group of people than if you're coming in saying that you're going to be transparent and make changes to rules. So let's be super clear about that and what your presentation was when you walked in the door. Pretty easy to figure out who I am, given that it's my name that's on our acute care statements and things like that. And I'm sure, Bill and I go back a few years, don't we, Bill? Just a couple. But I appreciate that. And I just want to be super clear. We had no idea that the conversations you had with the staff at Providence were part of an assessment of any rules revision or anything like that. Or trust me and government affairs would have been at the table. Thank you.
That's really important feedback, Robin. And like all parts of government, messaging and communication is always a place of continuous improvement. So we will take that feedback to heart for sure and work on messaging. I think we're at time. Are there any other comments or input? I think just in reference to this conversation, I think we can debrief this a little bit at our next work group meeting, and we'll add those of you from the hospitals that want to join that. And then if you do have other thoughts that come up after we adjourn today, please send those to us, and we'll incorporate those as we go through the process. And I see your chat there, Ron, and obviously you too, Robin. Robin, your hand is still up. Did you want to make a final comment? Okay. All right. Thank you, everyone. I know this has been a little bit painful. Hopefully folks felt today went a little bit better, and we'll just keep at it. And just a reminder, if you do have feedback on the process as Bill outlined, the kind of option 1, option 2 earlier at the beginning, please let us know. And we'll also bring that to the work groups and have more kind of informal conversation around that, not at an actual RAC, just to figure out the best way to move these changes forward.
Yeah.
All right, everyone. I see the sun is out in Portland, so try to get a little bit of vitamin D if you can. I've been at my desk for the last 8 hours, so I can't wait to get out there for 5 minutes. And we'll see you. I'm sure we'll see you in other spaces soon.
Wait, do you mind if I step in really quick?
Yeah.
Just a timeline for folks if you're interested. So we are attempting to incorporate all of your edits in this next week and hoping to file by the end of the month. Please note there are a lot of conversations that were had between today and the previous RAC, where we will be parking lotting a lot of those comments for that further deep dive review of the rule text. A lot of the comments and edits you will see will go back to that LIP and physician change, person first language, along with those 4 temp rules and the CMHP rule, seeing those changes. So don't be too alarmed if you don't see all of your comments incorporated, into the text. Those will definitely be reviewed during our next set of rule changes. So just noting, it's just combining those definitions and variance sections, focusing on those 4 temp rules, the person first language, the LIP language, and the CMHP tribal language in, I believe that was 930. So just a heads up on that. We'll be trying to get these filed by the end of the month. We are aiming to have our public hearing on February 15th, if we are able to still file our notice by the end of the month, and we'll keep you updated if something changes there. Then note, as soon as we file notice at the end of the month, it opens up a public comment period. That will go through the 21st of February. You'll have until February 21st at 5 p.m. to submit any written comment. We'll then have that public hearing, as I mentioned, on the 15th. That is an opportunity for everyone to provide oral comment. We do have an hour and a half scheduled for that time to provide comments. So hopefully come quick with a written list of all of your comments so we can get through them and to give people enough time to also go through their comments. If you're unable to give oral comment on that date, please forward any of your comments to Zach, Jesse, Bill, the rest of our team, so they are able to incorporate those edits. After the public comment period is closed on the 21st, we'll then incorporate all comments and feedback that were given, and then attempt to file a permanent rule by the end of March, if not early April. So far, that is our timeline. I know it kind of seems rushed, but that is what we have at this point. If you have any questions about the timeline for rulemaking, please reach out and let me know. I'm happy to answer those questions. And thank you all for attending today. It's been really great to work with you all, and hope you can enjoy the sun on this Monday afternoon. I hope you all take care. Thank you so much.
Thanks, everyone. Have a good day.
Thanks, everyone.
Bye.